We are live.
Madam, we are live now.
Okay.
So good evening, doctors and all the participants. I, Shuman, on behalf of Shield Healthcare, welcome you all in today's special program on Fetus Day by Foxy 2022. And the program topic is prenatal diagnosis, which is a very important one. And the program name is Fetus, your second client. So it's my honor to introduce our coordinator of this program today, Dr. Poonam Mishra, madam. Although madam doesn't need any kind of introduction, but it's my responsibility to introduce ma'am also. Ma'am is the president of Indian School of Aesthetic Gynecology. She is the chairperson of Cosmetic Gynecology, ISRM, SIG, member of Sexual Medicine Committee, Foxy India. Madam is the director of Manas Hospital, Manas Gynae Cosmetology and the Disaster Center and the Miracle Aesthetic Clinic, Lucknow. Madam is a practicing obstetrician and gynecologist with special interest in cosmetic gynecology, regenerative medicine, and sexual health. And in terms of academic activities, Madam organized and also participated in many national and international conferences as a faculty member and orator. So with this short introduction, I request Dr. Poonam ma'am to take over the session for further proceedings. Thank you very much for your gracious presence. Thank you.
Thank you so much, Mr. Suman. Thanks a lot for this generous introduction. And yes, today's platform again has been given by Shield Connect. And today is a very prestigious day, a very important day, the World Fetus Day. Since we all are gynecologists and obstetricians, in the first go, we all are obstetricians and gynecologists, and our direct client or the person in contact are the mothers, and the fetus in womb is the second client, you can say, or the indirect one. And the whole responsibility of a fetus is actually over the treating doctor. So the topic given today is this prenatal diagnosis is something very important, and this is the first of its own kind by Shield Connect in association with Indian School of Aesthetic Gynecology. And you all will be a bit surprised that is this something related to aesthetic medicine? Why is this topic here with aesthetic gynecology? So let me tell you that our first client are these mothers, and with the aging and with childbirth, once they deliver the baby, they have got many signatures over their body in the form of stretch marks and in the form of lax tummy and different kind of, you can say these are all actually signature marks with their pregnancy and the baby which is born. But the fact is that is giving a bit of concern to these ladies, and for that we aesthetic gynecologists are there. So we are there to assure them that let this pregnancy be very uneventful, very healthier one, and after a smooth delivery, you are going to be taken care of by the gynecologists you have been taking care throughout your pregnancy. The gynecologist who has taken care of that pregnancy, she's there for your aesthetic purposes also. So not to worry, and let's go ahead. So before starting our today's session, let's pray and let's remember our Mata Saraswati. And I will ask Shield Connect people, Mr. Suman, please do your lamp lightening session.
Saiti, no sound.
Beautiful, yes. Okay, that was really nice from you people, Mr. Suman. And yes, now it is the time to introduce our expert, Dr. Our speaker, Dr. Sangeeta Maheshwari. And she is from Dehradun. She is a leading practitioner and she has got a very beautiful setup, an IVF setup. And she's the head of this, director of her Genesis IVF in Dehradun. And she has got a very keen interest in aesthetic gynecology also. So I am welcoming here Sangeeta and Dr. Sangeeta. And here again, I would like to introduce our expert also because of some emergency. She is not here, Dr. Vidya Pancholia, none other than Dr. Vidya Pancholia, ma'am. She's a very senior obstetrician and gynecologist with the huge name in aesthetic gynecology. Actually, she is one of the pioneers in aesthetic gynecology in India, and we are blessed to have her in our group as a mentor, as an expert. She has always been guiding in in our different situations. Whenever I ask, whenever I need some guidance, she has always been there. Due to some emergency, she is not joining right now, but she would be there at the end of the program with her expert opinions. So I am now handing over the session to Dr. Sangeeta. Dr. Sangeeta, welcome, dear. The dais is yours now.
Thank you, ma'am. Thank you so much for the kind words. And thank you for providing me this opportunity. And thank you, Shield Connect, also for providing this platform and for providing the scientific content to us. And I think, ma'am, should we start the session?
Yes, ma'am.
Share my screen. I hope my screen is visible now.
Yes, ma'am.
So today's topic is prenatal diagnosis. As Poonam ma'am has already elaborated the importance of the prenatal diagnosis, as fetus is another client. We have two clients together. And this prenatal diagnosis is, it comes under the purview of PCPNDT Act. The procedures undertaken to diagnose genetic abnormalities and structural anomalies in an early embryo and fetus in order to undertake timely prenatal counseling and appropriate interventions. This prenatal diagnosis allows timely termination of an affected pregnancy, thereby preventing a potential cause of perinatal mortality. It allows a timely medical termination of a fetal condition before birth, and parents can decide whether they want to continue the pregnancy or they want to abort the fetus. It also helps to let them prepare psychologically, socially, financially, and medically for a baby that will be arriving with certain health problems. It determines the outcome of the pregnancy. The prenatal diagnosis is offered to all the high-risk groups that include advanced maternal age, history of a previous child with a chromosomal abnormality, women who are pregnant with multiple pregnancies, family history of a single gene disorder or a neural tube defect, or a history of congenital abnormalities in a previous child or a family member. If an abnormality is identified during the current pregnancy, or women who have had multiple miscarriages, or they have some other high risk factors like consanguinity or poor obstetrical history or a chronic maternal illness. Fetal medicine is a rapidly evolving branch of obs and gynae, and only in past few decades has the fetus been considered a patient and became the subject of extensive scientific study and attempts at treatment. Fetal medicine is a complex multidisciplinary undertaking with a team. It involves two things: fetal diagnosis and fetal therapy. We are mainly going to discuss fetal diagnosis. The benefits of prenatal diagnosis of fetal abnormalities are: a malformation incompatible with life may be terminated. Certain abnormalities may be correctable in utero, provides opportunity to arrange corrective measures beforehand, and offering a chance to be delivered at a place where the required facilities are available. That is transfer in utero. Parents' decision to continue the pregnancy or mentally prepare to have an affected child. The congenital abnormalities can be chromosomal, structural abnormalities affecting various organ systems, or genetic disorders like inborn errors of metabolism or hemoglobinopathies. The methods of prenatal diagnosis can be invasive or non-invasive. The first step is to go for non-invasive diagnosis, and that is basically through ultrasound, serum screening, cell-free fetal DNA, that is NIPT, and in certain cases, a fetal MRI is done. Invasive methods are done once the non-invasive tests have indicated some disorder. Amniocentesis is the most commonly performed test. Besides that, CVS is done, chorionic villus sampling, then fetal biopsy, and chordocentesis is done. Every pregnancy should be evaluated with the most definite test. This is the ideal situation. But this is practically and economically not feasible because most of the tests are very expensive and some of them are invasive. The worldwide practice is to carry out certain screening procedures and then run the diagnostic test for screen positive patients. There is a concept of universal screening because we have to offer the screening test to all the women. It's not something that we offer only to 35 plus women, because 70 to 80% of the trisomy 21 babies are born to mothers less than 35 years of age. The first step of screening is the history itself: maternal age, history of congenital anomalies in the previous children, a family history of stillbirth, consanguineous marriages, or recurrent first trimester abortions. They help us make a diagnosis that we might be dealing with a patient who may require certain prenatal diagnostic tests. Certain features in the current pregnancy, like history of some drug intake, radiation exposure, a maternal chronic disease, or a uterine height disparity with the dates, decreased fetal movements, fetal malpresentations, and history of viral infections in early pregnancy. Ultrasound is the first test that we offer to all the pregnant women, and this is a screening tool in all trimesters. At 11 to 13 plus 6 weeks, we do a NT scan, that is if the nuchal fold thickness is more than 2.5 mm, there is an association with the chromosomal anomalies. This has to be correlated with the crown rump length, that should be between 45 to 84 mm. Then at 18 to 20 weeks, we do level 2 scans. That is actually a genetic sonogram kind of thing, which detects 75% of the fetal anomalies. These are certain films that show how the NT scan is done and how some of the anomalies like cleft lip and palate can be diagnosed with an ultrasound. Nuchal translucency is the most important procedure done at the end of the first trimester, and there is subcutaneous accumulation of fluid in the fetal neck during the first trimester, and this translucency resolves in the second trimester, but it may persist in certain cases like cystic hygroma or as nuchal edema in certain fetuses. The cause of this increased nuchal translucency are cardiac defects where there is cardiac failure and thus there is subcutaneous edema. There may be abnormal development of lymphatics, and that is leading to impaired drainage of the lymph, and that is causing subcutaneous edema. Hematological diseases causing fetal anemia, chromosomal abnormalities wherein all the organ systems may be involved, pulmonary malformations that may lead to venous congestion, and that leads to subcutaneous edema. Skeletal dysplasias where the fetal movements are restricted because of the neuromuscular disorders, and then there is subcutaneous edema. Certain metabolic disorders can cause an alteration in the composition of extracellular matrix, and that leads to increased nuchal translucency. Another very important parameter to be seen in the first trimester scan at 11 to 13 plus 6 weeks is ductus venosus flow and tricuspid regurgitation. These require Doppler settings, and there is a decrease or reversal of flow in ductus venosus at 11 to 13 plus 6 scan is seen in chromosomal aneuploidy and cardiac anomalies, and these are associated with adverse fetal outcomes. Seeing these parameters requires a lot of operator skill and time, but nowadays most of the radiologists are observing these parameters. Tricuspid regurgitation is seen in a 4-chamber view, and even if the fetus is chromosomally normal, if this finding has been there, that fetus has to be followed carefully for cardiac anomalies. There is also a mild increase in the heart rate of trisomy 21 fetuses, so this point should be kept in mind. The second step of screening is maternal blood test, where in the maternal serum alpha-fetoprotein, the most important marker, the most important serum analyte is assessed. This is produced by the fetus and it enters into the maternal circulation. In the first trimester, yolk sac produces this and the liver produces it in the second and third trimester. It's a protein similar to albumin, but its role in the fetus is not well defined. Normally, it increases from 12 to 32 weeks, and then it declines. Abnormally, a rise is detected when the fetal capillaries are exposed to amniotic fluid. For example, in neural tube defects. Insulin-dependent diabetes patients have lower alpha-fetoprotein levels. Maternal serum alpha-fetoproteins are raised in cases of neural tube defects. If the neural tube defect is skin covered, then alpha-fetoprotein may be normal. We have to screen for neural tube defects at 11 to 16 weeks with the serum analytes. And if the reports are positive, then we have to do a detailed ultrasound examination. Alpha-fetoprotein levels may be raised in the following conditions: miscalculated dates, multiple pregnancies, threatened abortions, intrauterine deaths, oligohydramnios, IUGR, premature rupture of membrane or PIH, sacrococcygeal teratoma, congenital nephrosis, renal abnormalities, anterior abdominal wall defects, and bowel abnormalities. This is a flow chart which shows the prevalence of neural tube defects in our population. If we screen 1,000 patients, 950 patients will be normal. So we're going to be getting elevated levels of maternal serum alpha-fetoprotein only 50 patients. And that too, if a repeat sample is done, and if the dates are wrong and these are adjusted with the normal values, then almost 25 patients to 27 patients will go in the routine prenatal care. The rest of the patients will have an ultrasound which will show either the cause of maternal serum alpha-fetoprotein as multiple gestation, intrauterine death, or a neural tube defect. And then a further amniocentesis or a high resolution ultrasound will give us the cases of neural tube defects that will come out to be around 0.5 in every 1,000 cases. The Down syndrome risk. Low maternal serum alpha-fetoprotein is found in Down syndrome cases because most probably the cause has been abnormal placental transport. Fetal serum levels are normal and unconjugated estriol is decreased. HCG levels are high. The reason for these changes in these parameters are at 14 to 21 weeks, a normal fetus will have a rising alpha fetoprotein and unconjugated estriol, decreasing HCG. But Down syndrome has reverse. This is because of the functional immaturity of a Down syndrome placenta by 2 to 3 weeks compared to normal fetus. Dual marker or double test, which is done at the end of the first trimester. The plasma protein A and beta HCG levels are seen. And double test along with maternal age can diagnose up to 60% cases of Down syndrome. Triple test is less often done because nowadays we go for a dual marker along with anti-scan. And triple test has alpha fetoprotein, beta HCG, and unconjugated estriol. This is best carried at 15 to 18 weeks. And in trisomy 21, 60% cases can be detected by triple test and maternal age. And a quadruple test is done at 18 weeks or so, along with the level 2. And this includes all the parameters done in triple test and inhibin A. And the detection ratio of this for Down syndrome is 76%. Based on the likelihood ratio of all the parameters, we can give the patient a risk assessment. And we have to see her age, serum analyte levels, and ultrasound findings. And that way we can place her into high risk, low risk, or intermediate risk groups. For serum analytes taken at 15 to 20 week sample, Down syndrome risk is said to be high when the values are in the 1 to 190 ratio. If the risk is high in 1 by 190 and above, then we'll offer her an ultrasound. And if the dates have been found correct, then the invasive test will be offered to the patient. If the dates are incorrect, then maybe we'll be repeating the serum analytes. This is the chart showing what happens to the various serum analytes in various genetic abnormalities and neural tube defects, and in case of wrong calculation of gestational age. Diagnostic tests are offered to all the high-risk women on the basis of positive screening tests. An ideal test should be least invasive, and it should diagnose a congenital abnormality in early pregnancy, and it should minimally interfere with developing pregnancy. And no such ideal diagnostic test is available. Most of the diagnostic tests have some or other complication associated with them. Counseling is the most important part before offering any prenatal diagnosis method. We have to organize an appointment with the couple. Both of them should be present to decide. And we have to explain to them the risk of occurrence of a congenital abnormality, all the tests available, their procedure, cost, diagnostic ability, benefits, and possible risks. Possible management plan has to be discussed. If termination of pregnancy is unacceptable for the couple, the diagnostic test would be fruitless, because we have to know beforehand that if the report is positive, what we are going to do. And if we are not offering termination, then actually there is no use of diagnosing the disease. Counseling should be non-directive, and it should allow an informed choice. The distinction between screening and diagnostic investigation should be clarified to the couple. The couple should be reminded that a normal test result does not rule out every genetic and structural abnormality in the baby. The non-invasive tests are ultrasound, level 2 ultrasound, that is a genetic sonogram. It is evaluation of the baby for a long time to detect a wide range of congenital anomalies. It is non-invasive, and diagnosis at the spot is possible. But it is only possible at a gestational age of 18 to 20 weeks. Color Doppler will further enhance the capability, especially for cardiac and renal anomalies. The most important scan that is offered is at 11 to 13 plus 6 weeks. Nuchal translucency is measured for a CRL 45 to 84 fetus. And because CRL is not valid after 14 weeks as the fetus becomes more flexed. Serum testing is valid only with accurate gestational age. And age plus dual marker plus anti-NB scan gives a 95% detection rate. A genetic sonogram, that is targeted imaging for fetal anomalies at 18 to 20 weeks, that is the level 2 ultrasound. The primary aim of this ultrasound is to prove normality. Soft markers. Very often the patients come with certain structures seen in the ultrasound, like a CP cyst or echogenic bowel, and that confuses the picture. The patient gets worried. These are the soft markers. These are the findings. They are variants of normal, but they are noteworthy as they increase the risk of an underlying aneuploidy. Individual soft markers will vary in the degree of association or likelihood ratio with the aneuploidy. These are the various soft markers that are seen: nuchal edema, choroid plexus cyst, echogenic intracardiac foci, single umbilical artery, echogenic bowel, ventriculomegaly, absent or hypoplastic nasal bone. These are the various soft markers that are seen by the radiologist. Invasive tests. These are done at a PCP-NDT recognized place, and a Form F and Form G are to be filled. Amniocentesis. That is the most commonly offered test. There is aspiration of amniotic fluid, which contains fetal cells, and this can be analyzed for bilirubin level, alpha-fetoprotein, acetylcholine esterase. And the cells will be used for karyotyping by doing a culture of 3 weeks. Various new techniques like PCR and FISH can give results in 48 hours. The preferred time for this test is 16 weeks of pregnancy, because less than 15 weeks amniocentesis carries a risk of talipes in the baby. Chorionic villus sampling, where fragments of placental tissue are collected, and rapidly dividing cytotrophoblastic cells are used for direct karyotyping, and the results are available within 48 hours. These are the best source of DNA also. But this can be performed at or after 10 weeks, because less than 9 weeks doing this CVS is associated with high risk of limb reduction defects in the fetus. The indications for CVS are DNA analysis for hemoglobinopathies, chromosomal abnormalities, and inborn errors of metabolism. Fetal blood sampling, where the fetal blood lymphocytes are rapidly cultured, and the test results will be available within 72 hours. The indications are prenatal diagnosis, and in cases of failed amniocentesis or mosaicism is found in amniotic fluid or a CVS sample, then this fetal blood sampling is done to confirm. We can also assess red cell alloimmunization status, cases of hydrops fetalis and viral infection. And this is associated with a very high rate of fetal loss. And it is also used, this technique is also used for blood transfusion in utero in cases of fetal anemias. Cordocentesis is done at the site of placental insertion of umbilical cord or abdominal insertion of the cord, intrahepatic fetal vein or fetal heart. The suitable time is more than 20 weeks and less than 28 weeks. The risk is bleeding from the site of puncture, cord hematoma, fetal bradycardia, and fetal death. New molecular analytical techniques. The fetal cells obtained by CVS and amniocentesis can be used for prenatal diagnosis for congenital anomalies by using southern blot, PCR, FISH, or whole exome sequencing. PCR, where DNA or RNA fragments will be amplified with the use of polymerase, And then that particular segment of DNA will be assessed, whether there is a loss of DNA or increase in the amount of DNA, and that way we can detect the trisomies or monosomies. Fish where fluorescent markers are used to attach to the chromosomes. Particular chromosome number markers are there, and when they attach to that particular chromosome, we can see those markers and detect whether there is an increase in the number of chromosomes or a decrease in a particular chromosome, that is a trisomy or a monosomy. Whole exome sequencing is a new technique which is mostly offered as a carrier screening tool for high-risk couples like consanguineous marriages and all, where we have multiple DDs and we are not able to pinpoint the diagnosis of that genetic disorder. Then this technique helps. Management of fetal anomalies. It is a tedious task and it requires a skillful, sympathetic, and professional approach. The management options are termination of pregnancy, in utero management, if possible, and conservative wait and watch policy. So in conclusion, the commonest indication of prenatal diagnosis is advanced maternal age, family history of chromosomal disorders, single gene or structural abnormality, and pregnancies with multiples. It can be carried out by non-invasive procedures like maternal serum alpha fetoprotein, for neural tube defects and serum screening tests for Down syndrome and ultrasound for structural abnormalities. Invasive procedures are like amniocentesis and CVS. These are required for diagnosis of chromosomal and single gene disorders, but these procedures have a risk of miscarriage that has to be explained to the patient. Thank you. Now the topic is open for questions and expert comments from Vidya ma'am and Poonam ma'am.
Excellent talk. Yes, and so soothingly you told everything about the topic. And actually, this is very important because in day-to-day practice, we are dealing with all these problems, and many times it is very difficult to know what to do and when to do, because each and every patient of ours is not able to get all these tests done. So we have to customize and we have to personalize the required diagnostic tests and other things to make, like to separate the patient, to keep in the high risk category or in the normal category and others. So, Dr. Sangeeta, let me congratulate you. You are a star speaker for ESAC, Indian School of Aesthetic Gynecology, and it was absolutely a superb topic. Somehow, I think yet Dr. Vidya has not joined us, and there must be some questions, Mr. Suman.
Madam, I have forwarded to Madam.
Okay. So, Dr. Sangeeta, you can take those questions if you want in the meantime. Mr. Suman, you can read if you want. If
Madam,
you
can you see?
Yes, I can see the question. The question asked is, if ultrasound is okay for presence of nasal bone, Doppler echo is okay, age is 35 years, blood HCG is high, amniocentesis is must, your opinion? No, amniocentesis is not must because blood HCG itself alone is just a screening procedure. This might be, we'll have to first see the HCG values and whether the blood was drawn at the right time and whether in the software we have put the correct gestational age or not. We have to see whether the CRL was between 45 and 84 or not. And most of the cases, this value comes to be wrong because either the gestational age was wrong or some of the parameters were wrong. So first we'll have to see and recalculate everything, and then only we can see. And direct amniocentesis, when all nasal bone is there, anti-scan is normal, fetal echo is normal, all is normal, then I don't think amniocentesis should be offered. We can go for a non-invasive test first, that is NIPT, and that will be quite reassuring for the patient. That's my take. Maybe Poonam ma'am can throw more light on this question.
No, very well answered. And the same take is mine also. Yeah. No other question is there?
Madam, we are searching. Just give me 1 minute time, ma'am. Saiti, can you please check once?
Yes, sir. No other questions, sir.
Madam, no other questions.
Okay, so no other questions are there, but as I told, these are this topic as such is something which is very close to we gynecologists are dealing with each and every of these things every day in our OPDs. We get some high risk patients, few high risk patients, and many times we need these diagnostic tools to get them screened. So the further things which are to be considered, as we all obstetricians are knowing, are very well versed with these diagnostic tools and this topic as such. But the fact is that we, as being aesthetic gynecologists, how come I just wanted Dr. Vidya to be here to throw some light on the aesthetic part of this motherhood. This is something, a lady becomes a mother, and a lady is incomplete without being a mother, without delivering a child. And once she delivers a baby, she, as I told, she gets a lot of things over her body, and many working females, very ambitious females who are actually very much concerned for their body and their beauty, whatsoever is visible outside, the other parts which are there inside also. For them, there should be something that is known as something which is aesthetically needed. So here I am announcing again that in the next topic of ours will be the mommy makeover, a little lightening program. Like, we would be throwing some lights on different aspects of mommy makeover, that a mother who has delivered a baby recently or in past, or is having a lot of problems like saggings, SUIs, the stress urinary incontinence, mixed urinary incontinence, which actually gets worsened with the aging as well as with different birth trauma or other sort of trauma. And the as we discussed, those stretch marks, those sagging tummy, hyperpigmented scars, mons, protruding mons, sagging mons, and large labia, the hyperpigmented areola and hyperpigmented private parts, sagging breasts. These all are causing some sort of concern to the modern females. तो आज की महिला की सच्ची सहेली एक एस्थेटिक गायनेकोलॉजिस्ट. मेरा तो यही एक सबके लिए संदेश है. And yes, let's do something. This is an advice to my fellow members, my delegates, that we should actually do many awareness programs also among those who are non-medicos, those who know not much about these medical terminologies. we should organize some programs. We should tell them that the treatment for these problems, once they are in their milder phase or once they are going to be moderate, they should seek the medical advice, they should reach the doctors. And as my friend Dr. Anita Singh, who is the secretary of this Indian School of Aesthetic Gynecology, she was telling that our paramedics should also be taught about these aesthetic medicine practices, because they are the persons who come into. Just a minute, Dr. Vidya is calling. Hello, Hanji ma'am. Ji ma'am. So, what I was telling, that our medical staff, these are the members who come into contact with the patients at once the patient enters the hospital. There, the patient tries to get some information that what kind of facilities are being provided in this center. Madam is doing some specialized work in which field, like an IVF setup is there to provide every sort of treatment to the couples and facilitates them to be parents, those who are living in despair and those who are not happy with the outcomes. They have taken the treatment in some other centers and other things. Like the way the staff is there. The first members of your hospital are those staff members. So don't you think that those staff members should also be taught about these aesthetic medicine also? They should be told that they are going to provide the preliminary information to these patients so that they may understand that they are living with those stigmas. Like many females are having frequent micturations. They should be told that this is the starting of their incontinence sort of problem, which is going to be severe in future. This is the starting of that problem. If she is having frequent micturation, many females are there who think that मैं तो कहीं भी जाने से पहले मुझे लू जाना पड़ता है, because as soon as I walk मैं थोड़ा सा भी चलती हूँ, as soon as I laugh loudly, I feel like going to the loo. So ये उन्हें बताना जरूरी है कि this is something they have to report to the doctor. And yes, there is the treatment as जैसे उनकी प्रेगनेंसी एंड उनकी होने वाले बच्चे की केयर हो रही है, in the same way they should be told that after delivery they are going to have some sort of problem, and that is going to be taken care of by their obstetrician only. Because in my opinion, every gynecologist, every obstetrician should be an aesthetic gynecologist also. So I think I should, Dr. Vidya is not getting the proper link. So I think Suman, Mr. Suman, you had to.
Yes, madam, I had shared.
Sent you. You have sent me the link, the speaker's link. I think I should forward that to her. And she actually is fumbling with all these buttons to join our program, but she's not able to. So let me tell her. So Sangeeta, Dr. Sangeeta, would you please be throwing some light on your inquiries and whatever you know and whatever you want to learn in future regarding aesthetic gynecology?
Ma'am, for like a practitioner, the practical points like acquisition of the equipments, the cost involved in the initial setup, and the basic procedures that we can start, like non-invasive and invasive. Depending upon our surgical capabilities, we can begin with the surgical procedures also. But to begin with, the non-invasive procedures should be discussed, and how to, because this is a new field, and how to market it actually, because in the general population there's not much awareness. So these three aspects I would like to be enlightened on, like
Exactly, and
equipments.
exactly the same. Yeah, we discussed that we should organize some awareness programs, because in that way we are going to give some sort of social services also, because the public who doesn't know that the treatments are available for the things which are milder, the diseases which are milder, only the severe conditions where they reach the doctor in their severe conditions of SUI, severe conditions of incontinences, prolapse uterus, and other things which are now out of control. They need surgical corrections. But in our aesthetic gynae procedures, we are dealing with non-invasive procedures also. So you are absolutely correct. That is also the need of the time. What else? I think Dr. Vidya Pancholia ma'am has joined us. Madam, welcome you. A warm welcome is being extended to you from myself and from the whole team. Dr. Sangeeta and the Shield Connect people are there. So are you there, ma'am? Are you able to listen to us? Vidya
Madam, you
ma'am,
are in mute. Vidya ma'am, you are in mute. Can you please
ma'am,
unmute?
अपने को unmute करिए. Hello. Hi, ma'am. मैम आपका वीडियो भी ऑन नहीं है एंड यू आर म्यूटेड एक्चुअली. आप खुद को अनम्यूट कर सकती हैं. Mrs. Shah, can you unmute her?
Madam, unmute.
Yes, ma'am, I'm trying.
No, madam, unmute it. Vidya ma'am, can you hear us? Saiti, I guess Vidya ma'am is unmuted.
Yes, sir.
Yeah, madam, Vidya ma'am is unmuted.
Okay. Hello, ma'am. Let's wait. Let's wait for 1 minute, I think. There must be some problem on her side. Vidya ma'am. Hello. So if Vidya ma'am could join us, then we are going to be benefited actually from her experience. And let me tell you all that she is having the erbium yak laser, one of the costliest laser machine available in India.
Madam, sorry to interrupt. Just I got one message from Dr. Poonam. Let me check once, just in the chat box. Please show flow chart.
Flow chart regarding what? Like she needs
Actually,
some.
the comment is, ma'am, please show flow chart.
Okay, maybe she's asking for all the tests in the flow chart form.
Yeah, ma'am. Sangeeta, ma'am, I guess so. Madam, you are in mute.
Right now,
Should I send in the WhatsApp group, ma'am?
Yeah.
Yes.
I'll send the slides in the WhatsApp group.
Exactly. That would be posted and in the form of a flow chart. Also, if we prepare it, and then we will be posting in our groups and in our Indian Center of Aesthetic Gynecology group, because right now it is not available in the flow chart. I
And
think it's
madam,
later.
one comment from Dr. Ritu Saxena, ma'am. We need to discuss in detail with the patient, she has written. And another one, patient has to take a decision and not the doctor. I guess maybe this is related to amniocentesis or something. Sangeeta ma'am, can you please?
Yes, it is actually an informed choice, and I have shown in one of the slides that whatever counseling we are doing, it should be an informed choice. We cannot direct the patient to do. We have to offer them every option, and then the patient will decide whether they want to continue the pregnancy, whether they want to undergo those tests or not, because every invasive test has some inherent risk associated. So it is up to the patient. We cannot do a directive counseling. The patient has, we have to offer her everything, and patient has to decide.
Thank you, ma'am.
So no more questions, no more comments.
Ill no, ma'am.
So any topic, if our delegates want to suggest that that should be covered in our further talks later, like I told, mommy makeover, what else, like Dr. Sangeeta, what is your opinion? As you said, as you raised 3 points for us, and you actually covered almost everything in those 3 points. So would you suggest any topic for our next session? As I told, that should be for mommy makeover and further.
Yes, ma'am. Mommy makeover would be a very good topic to start with, because that will give us a direction from where to start our aesthetic gynecology practice. Because most of us are beginners, and we have a lot to learn from you people. And to begin with, we should have a direction in which direction we have to mold our practice. Because at present, we are not aware that what all we can offer to the patient.
Very nice. Very nicely explained. Like the question has been very nicely explained.
Sorry for the interruption, ma'am. Dr. Vidya
Vidya
ma'am's video
ma'am,
is working,
yeah,
but I don't know
Vidya
whether
ma'am
ma'am
is
can.
here.
Yeah, video is
Welcome,
working, ma'am.
Vidya ma'am.
Yes, Poonam.
Yeah.
It is started on my phone, but
Thank you so much. Thank God.
yes. So
So you are here. I'm so happy.
from one of the
Welcome, ma'am. And friends, I would like to tell you all that the topic for today's session, this prenatal diagnostic tools and whatever has been available, was actually suggested by our Dr. Vidya ma'am. She had asked that this is something very important and this should be discussed. And afterwards, once a lady becomes a mother, whatever is needed is going to be taken care of in our next lecture. And today, Dr. Vidya is there to give us some sort of introduction to that aesthetic gynecology, that part of taking care of a mother, a mommy makeover sort of thing. So, ma'am,
Poonam, am I audible?
yours. Yeah, ma'am, you are very much audible.
Yes. So a very, very warm welcome to all of you for the Indian College first. And now we can say this is the fastest growing subspecialty of gynecology. Previously, as you all must be knowing, that it was something related to the aesthetic or look of her intimate genital parts. And that time it was actually got so much opposition from everywhere in the world that it is something what you are doing is genital mutilation. Everybody has got its own type of look and configuration of this part. But in the couple of years when it has turned into functionality part, as it is a great demand, and now everybody is realizing ki, oh, I am having every day these type of cases where I am actually stuck up, don't have any type of say modality or treatment where I can treat all these conditions which are actually giving her trouble and affecting quality of life. And in the second part, we can say that if this is in a great demand, and if we have that knowledge of whatever treatment modalities we can offer, then it will be a wonder for every woman. And in India, we have a lot of hopes because we could streamline cosmetic gynecology in Foxy by this time. It is almost 5 years when we are there in this field more aggressively. And I could see so many Foxy conferences they are making as an integral part of the workshops. And somewhere I could see that urogynecology and some part of urogynecology is deleted from the mainstream of Foxy, where there are large number of very, very difficult operations were actually not shown, but theoretically discussed. And it is replaced by our cosmetic gynecology. And I am really feeling wonderful and giving you all a big congratulations that you got a special interest towards this field. And I am promising you with this initial stages of Indian college, we are going to discuss so many new things in a very methodical manner so that you can also indulge into this modality. And it is World Fetus Day, and we have talked about the prenatal diagnosis, a word about this. See, if we see or give an insight into epigenetics of any woman, then it is very, very sure that every gamete, not only ovum, but sperms, both are affected by environment. And there are so many genetic problems, they are there in this era. And we can actually challenge a genetic of any person if we are very, very vigilant into epigenetic part of gynecology. And if we give a proper novel nutrition, we can have so many say inhibitions to hyperhomocystinemia and whatnot. And in the same way, if the sperms are not good, so we can actually change its scenario from few of our efforts. And if gametes are good, then the implantation will be better. If we give a good environment to the patient, then the embryo will be better. And you can prevent so many anomalies. So I strongly feel what Dr. Sangeeta Maheshwari actually explained us in a prenatal diagnosis. It is very, very important. So that if there is some mishappening into this pregnancy, that can be a lesson to us. And always, if some patient or adolescent girl, if visit to your clinic for any other reason, still you should supplement her good folic acid, that is that should be in an active metabolite. As we all know that Indian population is very, very high in homocysteine. and simple folic acid preparations will not help them. So have a vision for epigenetic changes that can help that women in a better outcome of her pregnancy. So this is all for World Fetus Day, and welcome, and I really appreciate your interest towards field of cosmetic gynecology. Dear friends, it is nothing cosmetic. It is all functionality, as Dr. Poona must have told you that what are the basic needs that actually gives trouble as a quality of life. So we will join hands and we will learn, and any time, any difficulties, yes, we are there, and we will going to meet even for in the future with very good workshops. So welcome all of you, and thank you, Poonam, for taking such a big initiative all over India to cater the gynecologists who want to be in this subject, but for some other reason they are not getting a proper platform, or sometimes in the initial period they are not so happy to pay a big amount where they are not sure that they can do something in this field. So welcome all of you, and thank you very much, Shield, for giving us such a great platform.
Thank you very much, madam. Just meanwhile, I would like to mention that we have received another question that is dual marker in twin pregnancy should be carried out or not? For Sangeeta ma'am.
The software has to be fed that it is a dual, this is a twin pregnancy. Then only it can calculate. The software, if fed that it is a singleton pregnancy, then it will show a high risk because all the parameters will be raised, and then that will categorize it as a positive dual test. So if the software is fed the proper gestational age, it has certain, if we have seen the report, there are certain points which most of the labs do not mention, like whether it's an IVF pregnancy, whether there is a history of diabetes, what is the age, if it is a donor, then what is the age of the donor, if it is a twin pregnancy, what is the CRL in the NT scan, or if all these parameters are fed properly into that software, then only it can give you a proper risk ratio.
Thank you, ma'am.
So I think we have covered each and every part of this diagnostic tool, as well as diagnostic part, as well as the aesthetic gynae, a bit of introduction to the subject by Dr. Vidya ma'am. She has very nicely elaborated the need and the whatever is needed by our society, as well as the keen doctors should know about the subject. Each and every aspect of that ma'am has elaborated, and in our further lectures we would be able to get blessings from her. And thank you so much, Dr. Sangeeta. The subject has been very nicely taken complete care of each and everything by you. And thank you so much, Vidya ma'am, for being here as an expert. Thanks a lot to Shield people, Mr. Suman, Mr. Saiti, to provide the platform for us. Wish you all the very best of luck, and wish you all a very bright future in this aesthetic gynecology. Thank you, friends. See you all in our next lecture. Bye-bye.
Thank you very much, madam, for providing this nice lecture, especially Sangeeta ma'am, Vidya ma'am, and Poonam ma'am for your tedious effort to make this program successful, especially for the Fetus Day 2022. Thank you very much, madam, for all your
Thank you very
presence.
much.